And I'm going to be presenting research-based evidence for non-surgical management of ACL injuries. Okay, so anyone who has been following this kind of area of rehab or injury in the last probably 18 months would have come across the cross-bracing protocol out of Oz. So the idea is that it's a structured rehabilitation approach to facilitate natural ACL healing with prolonged immobilization in 90 degrees of flexion, and then progressively increasing the range and the function. It's best for young patients, athletes, but individuals also, just anyone looking to promote ACL healing and avoid surgery. The key phases effectively are first 4 weeks where you need to be immobilizing the knee. The concept of keeping it at 90 degrees of flexion is because the ACL, the anteromedial bundle is tightest in flexion, deep flexion, and the posterolateral bundle is tightest in full extension. So if you keep it in the middle, theoretically the two ends are closer together and they might attach and they might heal. So that's why you want to be quite strict with the bracing in the beginning. After 4 weeks, you gradually increase the range until 12 weeks, and then obviously all of your normal strengthening, neuromuscular control, etc., and then transitioning into sport-specific rehab would continue from there. So nothing really different beyond that first bracing period. There's very good evidence around this, but it is quite new, so we probably need to wait a few years to see what comes of it. There are a few catches. It requires a hell of a lot of patient adherence. It's not an easy thing to tell a patient that they need to be in a brace locked at 90 degrees for 4 weeks, especially when they know literally thousands of other people who've had ACLs and they are, running around, walking around after a couple of weeks. So quite a tricky thing to get patients' minds around, I think. Not ideal for anything chronic, obviously, because if you're thinking that the ends are going to join, that needs to be in a very acute injury. And then obviously there's, with the lack of activity in that acute swelling phase, the knee bent at 90 degrees, circulation isn't great, and there's a risk of DVT because you're not putting your foot on the ground and weight bearing, obviously, with a 90-degree knee. So your calf isn't working to improve circulation as well. So this would be kind of your typical process that we currently would follow would be the progressive neuromuscular rehabilitation. It's a fancy name for effectively what we're doing currently. So there's nothing really exciting to discuss here. It's typically for people with decent knee stability, a partial tear, or just anyone, again, who's really hell-bent on avoiding surgery. The key phases in the first 4 weeks, again, in this process, we're probably looking more at criteria-based stuff. One of the previous speakers spoke about criteria-based approach. But if you're looking at research, all of it is still technically talking about time periods. But the common sense stuff, pain control, swelling reduction, you want the muscles to work and you want the joint to move. You're gradually going to increase that. You're going to stress them out, start to add proprioceptive exercises, etc. And then once you get towards the back end, when you think that it's safe to do so and add some impact, you're going to start looking at sport-specific behavior. I'm sorry. The key to this part is, again, that criteria-based stuff. So you're looking at not just sending them back to sport at a certain point in time, but having them pass limb symmetry index tests, hop tests, etc., so that you can benchmark them and then compared to the other leg, and make an informed decision based on when you think it will be safe for them to go back to their activity. There's a lot of evidence for this, but honestly, it's not any better than surgery. It's just there's a hell of a lot of evidence for it. So it's probably like that gray zone, and this is kind of how we all practice, unfortunately, in ACLs, is that depending on the person, the first person the athlete or the patient goes to, they tend to either be surgical, non-surgical, and then everyone kind of has their biases, and they all explain their biases along the way until that line crosses over again. So non-surgical patients tend to often get surgery down the line sometimes, and surgical patients tend to complain about how they shouldn't have had their surgery, and they always wish they hadn't done their surgery. So it's a bit of a rock and a hard place situation, but this is kind of, as I said, where we are at the moment. I think this is the most representative one, this PNR concept. It might not be effective for high-demand athletes, so you're cutting, you're landing, those kind of things. So when surgeons are identifying these athletes early, they might dissuade them and say, listen, if you're a high-functioning athlete, for example, a Premier League footballer, a professional rugby player, etc., the window for your career isn't great, so let's just try and get you back on the field as soon as possible, and there's probably a slightly more predictable path, let's put it that way, with the surgery. There also could be other secondary injuries if it isn't, if the stability persists. And then your COPA versus non-COPA, everyone knows this. And I think, honestly, the previous one, the PNR and the COPA, non-COPA, is probably much the same thing. We're doing the same. We're using both principles, so it's not like one ends and the other begins. The concept around this one is that you're continuously reassessing the athlete to make sure if they can continue to cope or if they need surgery. And this is pretty much what I think most of us are doing. So your initial evaluation, your key early stage, is trying to say, well, listen, what's the downside of avoiding surgery at first? Let's try and do the conservative and non-surgical management if they, again, are not a Premier League footballer and the window isn't too small, etc. So this is what we try, telling the patient that, listen, we can always go back and do surgery. There's no window that shuts for surgery that can be done in 6 months' time, it can be done in 8 months' time. Obviously, you need to be sensible because you need stability and you need to make sure that there aren't other injuries that you're going to be potentially causing trouble with, like a meniscus or something like that. Again, the same process, stability, testing, functional scores. As long as there's no instability, you can continue. If there is instability, you need to then have an honest conversation with the person and say, right, well, based on your requirements, do you feel like this knee is able to fulfill what you need? And if it isn't, maybe you need to change your lifestyle and change your expectations. You might need to stop the sport you're hoping to play. Or if you do really want to go and play that sport, you then probably do need surgery. If we have given this a good crack and it hasn't worked, your knee is still not what you expected it to be. And much the same, once you're at a safe place, you're going to start the return to sport stuff. So there's a lot of evidence around this, but it's like a 50-50 situation. So again, with that continuous assessment, you're going to be in a good position, I think, and going back to the fact that I think the second and third options here are effectively a second option. So I would group them as the same. This is my approach for the PNR option anyway. I'm never going to say to an athlete, you're not going to do surgery. It's always like a trial kind of thing. But with the caveat that in a very high impact and high risk sport, you kind of have those conversations very early, and you need to have that athlete understanding that if their knee doesn't feel like it's going to do what they need to do, let's say a badminton player, for example, they might want their hardest, or they might want to try their hardest not to have surgery. But after 4 or 5 months, if a badminton player can't jump to the back court and support themselves and get back into the middle court, they're going to tell you openly, listen, it's not working out, they need to do something else. And then you'd pull in one of your surgical colleagues. So effectively, the final summary here is the cross-bracing protocol, or a variation. I mentioned a variation here because if you think of that concept of 90 degrees, it possibly doesn't have to be exactly 90 degrees, and this is where the research is very early as well. It's only one group in Australia who's really published on this, and it's, I think it was 80 athletes that they published on, or 80 individuals. So if we could potentially change that flexion angle to maybe like 30 or 40 degrees, where the ACL is potentially not as lax, but not completely taut, they might be slightly more functional. You might be allowing them a little bit more weight bearing. Their calf might work, and there's the risk of the DVT isn't there or is reduced, and that might be a better way to do it. But it's a good idea for young active populations with a good possibility of healing. The NMR and the COPA is effectively, as I said, a summary of what we are currently doing. I think is the most prominent thing that we're doing right now, where we are taking athletes and we're looking at their options early, but we're keeping the door open. So we're saying, right, can you do this? Can you do that? Right, let's move on to the next thing. If you can't do it, we need to kind of have an honest conversation and say, right, if your expectation is up here and you're over here, are you willing to wait for a very long time, or is the window closing on your sports career and maybe we need to go a little bit earlier? So that's effectively the three concepts that are out there that there is decent amount of evidence for at the moment, but neither of them are superior to any of the other at the moment, I wouldn't think. Thank you very much.